Next speaker is Jignesh Patel. He's the medical director of the cardiac transplant program at Cedars. He's going to share his expertise in the management of advanced heart failure, the role of devices, and probably he promised me he won't torture our mind with a lot of complexity. So I'm going to hold you to that.
Yeah, thanks very much. I wanted to thank Bridge and everyone here at CCMC for organizing this great event and giving me the opportunity to really go into some of the work that we've been doing and has been really involving a lot of patients that have been sent down from Bakersfield. I'm just going to be talking about one off-label drug as a disclosure, levosimendan. Heart failure has really become an epidemic in the 80s and 90s, and the number of hospitalizations have continued to increase. This data comes up to 2006, but since that time, CMS and the government has really been hammering the hospitals in terms of reducing hospitalizations for heart failure. And there has been some beneficial effect, and this curve is now starting to plateau and even come down. So outpatient therapy for heart failure is really having an impact in terms of inpatient management. What are the heart failure hospitalizations due to? Well, the vast majority of hospitalizations are due to worsening of chronic heart failure, and about 50% of these are due to preserved ejection fraction, and the other half are due to systolic dysfunction, or what we call heart failure with reduced ejection fraction. About 25% of patients are new presentations for heart failure. These may be patients with post-MI, hypertension, or post-viral, and only about 5% of patients present for management of end-stage heart disease. Now, there are a number of similarities between acute coronary syndromes and acute decompensated heart failure. The incidence in the United States is about the same between the two diseases, about 1 million per year. Inpatient mortality is about the same at 3 to 4%. However, the outpatient mortality in the first 90 days following heart failure hospitalization is as high as 10% compared to just 2% for acute coronary syndromes. And the reason for this is that there are very clearly well-defined pathophysiological targets for acute coronary syndromes, whereas for acute decompensated heart failure, we're still somewhat in the dark in terms of how to identify the pathophysiology and treat it. With regard to clinical benefits of interventions in published clinical trials, there are many proven therapies for acute coronary syndrome, such that many patients are now just going home the next day after their percutaneous interventions and medical therapies, whereas for acute decompensated heart failure, there really are no positive clinical trials. And so there are no AHA-ACC recommendations for decompensated heart failure, whereas for acute coronary syndromes, there are many level A indications. And the natural history of heart failure is that following initial myocardial injury, there's a slow progression of deterioration in myocardial viability, which is accentuated by acute episodes of heart failure. And the reasons for these may be multiple, whether it may be patient dietary indiscretion or a new acute coronary syndrome, uncontrolled hypertension. However, it does lead to progressive decline in cardiac function and eventual death, such that about 5 million people in the United States are affected with chronic heart failure and about 10 million in Europe. What are the predictors of mortality in acute heart failure? From a clinical standpoint, it's fairly simple. It's congestion, hyponatremia, which affects about 20% of patients, renal insufficiency, and hypotension. You'll notice I haven't mentioned ejection fraction or hemodynamics, and while they do have an impact, and Dr. Chuk may go into that later on, these are really the clinical predictors for whether a patient will have a chance of leaving the hospital or not. And when we look at congestion, this is data from the ADHERE registry, seeing that while most patients present with congestion, and these are data from over 26,000 patients, the number of patients who undergo significant diuresis is fairly modest. In fact, 20% of patients gain weight while they're in the hospital, and only about 75% of patients, or 70% of patients, have any significant diuresis. The mean diuresis is about 6 pounds per hospitalization. There are biomarkers which help us with the diagnosis of heart failure, and BNP is probably the best established, and we know that it's elevated in both patients with systolic heart failure and heart failure with preserved ejection fraction. And we also know that it is a prognostic marker. In this data, the presence of an elevated BNP at the time of discharge from hospital for heart failure was correlated with mortality, such that if your BNP was greater than 700, this represented a 15-fold increase in mortality compared to if your BNP was less than 350. And this is 180-day mortality. That's mortality at 6 months following hospitalization. So this is a very malignant disease, and it's very comparable to most of the cancers that we see in our patient population. Unfortunately, BNP is not a good predictor of hemodynamics. There's a very widespread difference in the presentation with regard to BNP values and wedge pressure. So although it's elevated, it doesn't really give you an idea of how badly the patient is doing. What are the best clinical predictors of heart failure and presentation? Well, this is an algorithm that was suggested by Lindborn Stevenson a few years ago, looking at just how you assess a patient from the end of the bed and get an idea of what's going on hemodynamically. The normal patient is described as being warm and dry, and that represents somebody who doesn't have congestion or has a low pulmonary capillary wedge pressure and a good cardiac index. If the patient is warm and wet, then the suggestion is that they have a high capillary wedge pressure, but their cardiac index is pretty well preserved. They're able to pump blood to their peripheries. If there's evidence of hypoperfusion with congestion, then the patient will be cold and wet with an elevated wedge pressure and also a decreased cardiac index. And the sickest patient may represent with hypoperfusion when they're dry, but also cold with a decreased index. What are the main management strategies for these patients? Well, with congestion, we typically diurese these patients. When they have a decreased cardiac output, we use inotropes. And if there's room for blood pressure, we will use vasodilators to reduce their systemic vascular resistance. Well, what about these therapies? Let's look at inotropes. These have been available for many years, and we have a few that are available for our clinical use. Unfortunately, not a single inotrope has been shown to be beneficial in terms of mortality. In fact, all inotropes increase mortality. Milrinone has been associated with a 28% increase in mortality versus placebo in the PROMISE trial. There was a whole bunch of drugs that were tried out in clinical trials, including resnarenone, zamaterol, ibopamine, and pimomendan, all of them associated with increased mortality. Pimomendan, interestingly, is an oral agent and is available if your dog has heart failure. Another class of agents was fairly recently investigated. These are calcium sensitizing agents. These exert a positive inotropic action by increasing sensitivity of the contractile apparatus to calcium. So there's a lot of enthusiasm with this class of drugs because theoretically these agents may increase myocardial contractility without increasing intracellular cyclic AMP or calcium, and therefore might avoid the major limitations of the typical inotropes that we already have which contribute to increased mortality. And certainly the initial clinical trials, the REVIVE-2 trial, showed that patients did feel better, at least compared to placebo, when levosimendan, which is the first calcium sensitizing agent that became available for investigational use. And certainly these patients felt better in the short term, at least up to 5 days. However, despite their novel mechanism of action, they did have side effects, including more hypotension, increased arrhythmias, including ventricular tachycardia and atrial fibrillation. So somewhat problematic. And when the study was done comparing with dobutamine, there was no difference in mortality at 6 months with the use of levosimendan. Given these fairly comparable findings, the manufacturers never proceeded with FDA approval in the United States, although the drug is available in Europe. So we're still stuck with dopamine, dobutamine, and loranone. What about congestion? Well, loop diuretics have really been the first line of agents for patients with congestion. However, a number of older studies have shown that they may not be the best thing in a patient with a failing heart. This is a very small study that was performed looking at the effect on renal function with intravenous diuretic use. It shows that with IV furosemide, there is an acute decrease in glomerular filtration rate when the drug is given. And this data from the Cleveland Clinic shows that there's even an adverse effect on the hemodynamic profile when you give intravenous furosemide, such that when you measure right heart pressures at 20 minutes after infusion, the pulmonary capillary wedge pressure actually goes up, and the stroke volume index goes down, heart rate goes up, mean arterial pressure goes up, and SVR also goes up. And if you look at circulating neuroadrenergic markers, these all go up, and these are plasma renin-angiotensin and plasma norepinephrine both go up, and we know that these neuroendocrine markers, elevation of these neuroendocrine markers, are not a good thing in heart failure. So are there any alternatives available to loop diuretics? Well, more recently, ultrafiltration has been looked at, and this has come into favor because the technology has improved such that the device allows you to perform ultrafiltration via peripheral intravenous access. And the principles of this is that it provides an additional modality for fluid removal, and you can literally dial up the amount of fluid that you want to remove from the patient up to 500 cc's per hour. It allows a predictable amount of fluid to be removed, unlike intravenous diuretics. And another advantage is that you are removing isotonic fluid as opposed to preferentially removing excess potassium and a hypotonic solution with loop diuretics. So the UNLOAD clinical trial was performed, and we participated in this a few years ago. And this compared peripheral ultrafiltration to routine standard care, which consisted of intravenous diuretics. And certainly weight loss was significantly improved with the use of ultrafiltration compared to intravenous diuretics. Interestingly, at 90 days, this reflected in a reduction in rehospitalization rates with ultrafiltration compared to intravenous diuretics. So there was quite a bit of enthusiasm that this may be a mode of therapy that might be a good alternative to diuretics. There were no clinically significant differences in terms of renal function, sodium chloride or bicarbonate levels. And in fact, during treatment, serum potassium level was well maintained in the ultrafiltration group, whereas almost 12% of patients in the diuretic group had hypokalemia. And interestingly enough, even though you could remove 500 cc's an hour, episodes of hypotension during the first 48 hours after randomization was similar in both arms. So it appeared to be pretty well tolerated. More recently, the treatment was looked at in really advanced patients with decompensated heart failure in conjunction with cardiorenal syndrome. And although this study had some design issues which are very controversial, the study suggested that ultrafiltration may not be so good in this group of patients, because although ultrafiltration was associated with an equivalent amount of weight loss compared to diuresis, there was a concurrent increase in creatinine or decrease in renal function with ultrafiltration compared to conventional diuretics. So it may be that ultrafiltration may not be the best option in patients who have developed renal dysfunction as a result of cardiorenal syndrome. What about vasodilators? Neseritide or E-type natriuretic peptide became very fashionable a few years ago. The reason for this is that it has a number of favorable hemodynamic, molecular, and renal effects. There's balanced vasodilation with dilatation of veins, arteries, and coronary arteries. There's decrease in neurohormonal activation. There's increased diuresis and also increased natriuresis. And at a molecular level, there are improved responses, including favorable lusotropic effects, antifibrotic effects, and anti-remodeling effects as well. And certainly, in terms of hemodynamics, unlike the diuretic data that I showed you, patients treated with neseritide compared to placebo had favorable hemodynamic profiles with a decrease in filling pressures and increase in cardiac index. And this was also correlated with improvements in neurohormonal profiles as well compared to baseline. So it appeared that this may be a very favorable alternative therapy for patients with acute decompensated heart failure. Well, to really determine whether this was an effective treatment and to determine whether there was any mortality benefit with this drug, the largest ever trial in acute decompensated heart failure was performed. This is a multinational study of over 7,000 patients called the ASCEND-HF trial, comparing neseritide with placebo. And the co-primary outcome was 30-day all-cause mortality or heart failure hospitalization. And unfortunately, compared to placebo, the data was very equivalent with neseritide. So at least at 30 days, it appeared that neseritide was beneficial in terms of improving mortality or hospitalization. There were some concerns in earlier studies that neseritide may also have an adverse effect on renal function, but in this larger study, it was very equivalent to placebo, so at least it didn't appear that it had adverse effects on renal function. However, the drug is associated with excess hypotension, whether it's symptomatic or asymptomatic, as might be expected for a vasodilator. So really to conclude, in terms of management of acute decompensated heart failure and medical therapy, rates really continue to increase and represent a substantial portion of healthcare costs. Right now it's about $30 billion for Medicare. The development is associated with significant mortality rates, but unfortunately current medical therapies, while they improve symptoms and hemodynamics, have really yet to demonstrate any beneficial impact on survival. So we kind of painted ourselves into a corner with medical therapy, and we've really been forced to think about alternative approaches for managing patients with end-stage heart disease and advanced heart failure. And really the only thing that's really become, which has really shown us some meaningful improvement in managing these very sick patients, is the development of mechanical circulatory support or mechanical assist devices. Now you'll see here the problem we have with the natural history of heart failure. At the bottom you'll see that the NYHA functional class from 1 to 4. As patients become progressively worse, they become more symptomatic. And once they develop NYHA class 3 symptoms, we see that the survival rate plummets drastically and the number of hospitalizations increased significantly. Now, this is a significant portion of the population. 25% of heart failure population has class 3 heart failure. They represent the bulk of patients who get end up in the hospital, and they end up with worsening symptoms despite drug therapy. And this group really represents a significant opportunity for newer therapies such as mechanical assist devices. For the purposes of determining candidates for mechanical assist devices, the classification for class 3 heart failure has really been subdivided into what we call Intermax profiles. These Intermax profiles are very helpful in determining how a patient is going to do going into an assist device implantation, such that patients who have an Intermax profile of 7 are very stable patients. Patients who have a profile of 3 are patients who are critically ill and cardiogenic shock but have been maintained relatively stable on inotropic therapy. And patients with Intermax profile 1 are really the crash and burn patients who are rapidly going downhill and developing end organ failure. So what are the advantages of using mechanical circulatory support in advanced heart failure? Clearly, mechanical support improves blood pressure and flow to organs until a suitable donor becomes available, should the patient be a candidate for transplant, something we call a bridge to transplant, or BTT. It reduces the need for IV inotropes that, as I mentioned earlier, can exacerbate arrhythmias, ischemia, and remodeling, and it's associated with increased mortality. It allows improved nutrition and functional status so that patients can actually get up and get out of bed, walk around, and get better nutrition, and may actually become better candidates for transplants. It also allows identification of poor or unacceptable candidates who we would not rush to a transplant given the scarcity of donor organs. It also provides an alternative to transplantation for patients who are, for example, too old for transplant or have other comorbidities which may preclude transplant, something we call destination therapy, or DT. And for many patients, it provides temporary support until the ventricle is able to recover. And about 4% of patients may be able to come off their assist device, or something we call bridge to recovery. What are the indications for mechanical support? Clearly, cardiogenic shock. Sometimes patients are unable to come off cardiopulmonary bypass after open heart surgery. Patients who become dependent on inotropes or temporary support, such as an intra-aortic balloon pump, nowadays Impella, or extracorporeal membrane oxygenation, or ECMO. Post-MI with shock, patients with incessant ventricular arrhythmias. We're increasingly seeing many patients who are being transferred over with VT storm. Patients who may have a prolonged wait for a suitable donor. So these may be either highly sensitized patients who may have antibodies that may limit their availability for suitable donors. Patients who may be on the large side, or blood type O, who may have a difficulty getting a suitable donor because blood type O's can only get hearts from other O donors, and it's the most common blood type. Patients with cardiorenal syndrome often need support to really get their kidney function better, so that they become become candidates for transplant. And patients who have really advanced symptoms despite optimal medical management in the office may be somebody who should be considered for mechanical circulatory support. And in some cases, patients who don't tolerate traditional heart failure therapy and can't get on any form of guideline-directed medical therapies should be considered for an assist device. What are the contraindications to an assist device? Irreversible major end organ failure. Once the patient has developed a renal failure or has significant hepatic dysfunction, that really means that it's really too late to consider mechanical support for these patients. Uncertain neurological status. Sometimes these patients get really sick and they end up getting intubated. They're on sedation. We really need to determine whether these patients are able to wake up before we can put a device in. Major strokes, recent bleeding because of the need for systemic anticoagulation following implant. Unresolved malignancy, active bleeding or significant coagulopathy. That also includes patients with significant hypercoagulable states because of the increased risk of pump thrombosis and strokes. Patients with ongoing sepsis. And something else that's really important is having an adequate social support system and ensuring that the patient is compliant to medical therapy, because the use of these devices is fairly complex, requires a lot of family support to make sure that patients do well with them. Advanced stage is a relative indication. We have a couple of patients with destination therapy. We had a radiologist who had one at the age of 82, and he's still doing well at the age of 85 with a device. Morbid obesity is also a relative contraindication, simply because these patients don't lose weight after the device is put in, and the increased weight is associated with increased complications from the device. And cachectic patients don't do well either. We do have a clinical trial at Cedars currently enrolling patients who are morbidly obese, who may be candidates for a mechanical device, whom we will be evaluating for gastric bypass surgery while the patient is on the device. So we do have a program where these patients may be eligible for surgical intervention after mechanical support for morbid obesity. And any progressive or systemic disorder which may limit survival, we won't consider for circulatory support. The key to successful outcome following implantation really depends on appropriate patient selection, and this includes selecting the appropriate device, putting in the device early before the patient develops advanced end organ damage. And really, it's really important to get these patients for implantation early on for evaluation, because it does take time to evaluate these patients. It takes time to get insurance for them, making sure that they have adequate social support, educating the family and the patient about what is involved with the device, what type of device they're going to have, and how they're going to live with the device afterwards. So we really like to get these patients in earlier for evaluation while they're still candidates. A few words on the type of devices that are currently available. Some of these have now become of historical interest. The paracorporeal devices, which involve implantation into the abdomen, include the Biomed Thoratec pneumatic Bivard and the Thoratec Centromag, which is still used. The intracorporeal systems, HeartMate 2, left ventricular assist device, hardware, Jarvik 2000, Micromed, DeBakey, and the Syncardia cardiovascular artificial heart. I'll go into more detail about some of these which are more commonly used. This is the Thoratec pneumatic Bivard system, which is a pneumatic system that supports both the left and right ventricle. While this was kind of the workhorse for our patients with biventricular failure a few years ago, this has now been superseded by the total artificial heart at Cedars-Sinai, simply because the outcomes are better with the total total artificial heart than this device. The continuous or axial flow devices have really changed this field significantly because of the number of patients who've been able to be treated with this. These devices are mechanically much more simple. They have a single moving part, they're silent and they're portable. The device size is much smaller. It reduces surgical morbidity and improves ease of implantation. And it really fits the majority of candidates. There are smaller drive lines, which reduces the infection rate, and there's a low thromboembolic rate. And these devices have really been shown to be effective at improving quality of life. And these have really now been shown to be very durable with estimated duration up to 8 to 10 years. The one that's most widely used currently is the Thoratec HeartMate 2. This is a device with a cannula in the LV apex and another cannula into the ascending aorta. It's a continuous flow. The drive line comes out of the abdomen and is connected to the controller and the battery pack. And the clinical trials looking at the HeartMate 2 as a bridge to transplant showed fairly good survival at 12 months at 70%. However, the post-trial data shows that we're now up to about 92% 1-year survival with this device. So as time has progressed, we've got really good at screening the patients and determining who will do well with these devices. So the 1-year survival at 92% is really very impressive, considering that many of these patients were at death's door at the time of implant. And in terms of functional status, these patients become improved very rapidly at 1 month. 60% of patients show improvement in functional status, so that they're either NYHA class 1 or 2. And by 6 months, 82% of patients are NYHA class 1 or 2. This device is now also approved by CMS for destination therapy. And in the clinical trial, which was performed, which showed the device to be appropriate for destination therapy, patients that were considered included patients with an ejection fraction of less than 25%, at a VO2 max of 14 mL per kilogram per minute, or less than 50% of predicted age and sex. This is a cardiopulmonary exercise test, and it is really a very helpful test in patients with advanced heart failure, because it determines their mortality, and the VO2 max of less than 14 is associated with an increased mortality. Patients who have advanced symptoms despite medical therapy within the last 60 days had been on inotropes or had been on a balloon pump were enrolled into this trial. And these were patients who were excluded from transplant. They had to have good renal, pulmonary, and hepatic function and no active infection. And the study really showed that compared to a historical control of the original rematch trial, which involved the HeartMate 1 pulse-style device, LVAD therapy was associated with significant improvement in survival at up to 60% at 24 months. And compared to the original device, there were fewer deaths from hemorrhagic stroke, less overall bleeding and infection. So the device is much better than the original pulse-style device. There are still problems with mechanical circulatory support. In the trial, about 20% of the patients died from sepsis, 13% died from right heart failure, and 9% from multi-organ failure. And the stroke rate was up to 18% of all deaths. So there are still issues with this. The overall stroke rate was about 4%, or just under 4% for all implants, and infection rate was about 4% of all implants. But we're getting better at managing these as we understand how to use these devices. These are very durable devices, and in terms of device failure or replacement requirements in the study, at 18 months, it was 92% of the patients were free from major malfunction from their device. The important clinical features to note about the HeartMate 2, and this is important if you have any patients in your practice with this device, is that they do not have a pulse, and the blood due to the continuous flow, and you have to take the blood pressure with a Doppler, and we tend to target a mean arterial pressure between 60 and 85 millimeters of mercury. All LVAD patients do require their native right ventricle to be intact to allow contribution to flow critical and to maintain their pulmonary vascular resistance on the low side. Patients do better if they're in sinus rhythm or have a controlled ventricular rate in atrial fibrillation, because that is important for right ventricular output. And all LVAD patients have functional defibrillators, and an external defibrillator can also be used if needed. Importantly, there are no valves in this system, so if you're performing cardiopulmonary resuscitation on these patients, don't do chest compressions, because all you're doing is you're moving blood back and forth across the device. It's not effective. And usually, if there's a problem with the device, we have a crank handle to deal with it. Systemic anticoagulation is required for all patients on a HeartMate 2, but there is an increased bleeding tendency which can be clinically significant, including GI bleeding. And the reason for this is that the non-pulse valve flow may contribute to the development of angiodysplasia within the GI tract. And there's also another issue which relates to a syndrome called acquired von Willebrand's syndrome. The von Willebrand's molecule is a large molecule, and it gets shredded up within the device. So the patients actually develop a coagulopathy while on the device, and therefore have a greater tendency towards bleeding. So you have to be more careful about that. Over 10,000 patients have now had a HeartMate 2. Survival is 85% and 73% at 1 and 2 years. It's approved by CMS. This is one of our patients who's 6 days post HeartMate 2 implant. He had the device for about a year before he got transplanted. He was transplanted in May 2011, and I just saw him in clinic last week, and he looked great. This is the most famous recipient of the HeartMate 2, and it's actually a great thing because patients ask about what is this device, and you say, oh, Dick Cheney had one, and everyone says, oh yeah, okay. If he can have one, I can have one. And he subsequently got transplanted as well. There are newer developments in the development of this technology. Hardware is the latest device. This is a much smaller device that goes straight into the apex without the need to go into the abdomen. And this device is actually, in our hands, having much better outcomes than the HeartMate 2. So we're now doing more hardware devices than HeartMate 2, and it's much easier to implant the device. The surgeons like doing this. They're even doing this through a lateral thoracotomy approach and without going on bypass. A quick word on the total artificial heart. This is the device that we've been using at Cedars, and Cedars is the #1 user of this device in the world. It is a biventricular pneumatic device that actually replaces the entire heart. You take the heart out and you put this device in. It is approved as a bridge to transplant, but not for destination therapy. It's suitable for patients with a mechanical aortic valve replacement. There are limitations. It requires full anticoagulation. There is an external driveline. You need patients have to be of a certain size because the device is quite big. There is a smaller device that will soon be available for pediatricians. Patients for total artificial heart, severe biventricular failure, cardiogenic shock with significant end organ dysfunction may be candidates, although we really balk at doing anything for those patients. Unique anatomic issues, patients who may have a cardiac tumor or cardiac malignancy. We've done it in patients with severe heart transplant rejection or allograft vasculopathy. Hypertrophs or amyloid patients are particularly suitable because they have very small ventricles, and those with VT or VF. The drivers for this device have improved significantly from this device that was at the bedside to a 13-pound device that patients can now go home with. The Freedom driver now allows patients to actually go home with this device. We've done about 56 devices last year at Cedars. We're up to 44. Our device types are changing, more THs, more hardware devices, and less HeartMate 2s and BiVads. About 75 to 80% of patients are surviving to transplant or have ongoing survival within our institution. The temporary devices are having an increasingly important role in making sure that the patient survives to the next step. So these are the impeller, tandem heart, ECMO, intra-aortic balloon pump. We also have, we're looking at the right-sided assist devices, including the impeller RF and the tandem right-sided support. So we are having more and more devices available for our use. And these are some of the future devices that are essentially getting smaller and smaller, and the target is to get rid of the driveline altogether and have implantable rechargeable batteries that allows the patient full freedom of mobility. So mechanical circulatory support represents an effective means to sustain life and recover organs in advanced heart failure. Successful outcome depends on good patient selection and expeditious referral. 1-year survival is really excellent. Smaller and simpler devices are continuing to be developed. The continuous flow devices have really become the device of choice for left ventricular support. And the sickest patients really require biventricular support. And advances will really, at some point, may surpass heart transplantation as a treatment of choice, given the limitations of organ supply for these patients. Thanks for your attention.